not in my GP practice, to be honest. I saw such cases in the emergency when they come in a crisis. So I met couple of them, two of them, and one of them I diagnosed, not even by doing kidney ultrasound, no, by doing a pancreatic ultrasound, because he came with query pancreatitis, and I did a bedside ultrasound scan, and then I saw there's multiple things in the pancreas, and then we look at the kidney, multiple things, and then the diagnosis was done, and we did the MRI to the brain, and we find another thing also in the brain. So yeah, you might find some cases, but we need to know the science behind it and why that's affecting multi cases. And we will learn that, multi-system. We'll learn that today, hopefully. Okay.
How will you share
And
the recordings?
you will hear
Will
it,
it be in
but
the group?
no, you will hear it. Don't worry, because I'm sharing my voice as well, so you will hear it. Yeah,
No,
I
no, I'm
try
saying
it.
how will you share the recordings? Will it be in the
Oh
group
yeah,
or
no, no, my dear. So there is a YouTube channel with the same name called SA Level Up. Okay, and the
okay.
PowerPoint, usually I would share it on the Facebook channel, which is something new. Okay, so we have three sources: the WhatsApp group, and then the YouTube channel, and then the Facebook. Okay, so each one will have part of the lecture. The
And
recording will be in the YouTube. The link to the meeting, live meeting, is in the WhatsApp, and then the Facebook have the PowerPoint. Okay. Yeah. So yeah, we'll start. The recording is going on. Yeah. So Satwat, can you see Dr. Satwat?
Yeah,
Yeah. So
okay.
yeah. Shall I start the 3 minutes?
Yeah,
Yeah. There is some down, okay? So just when you reach down, tell me to scroll down.
sure. Can you scroll down kindly? Yeah,
No, that's it. There's no more
that's
one.
okay. Can we scroll up?
Sure.
Good evening.
Yeah, good evening.
This is Dr. Satwat Moise from the surgery. Am I talking to Jack Whitehead?
Oh, yes, doctor. Thank you for calling.
Not at all. Is it all right to call you Jack?
Yeah, that's completely fine, doctor.
So, Jack, I'm aware we are here to discuss your scan results.
Oh, yeah, yeah, I think so. Yeah, this is what I received the call for. Yeah, they told me that you need to discuss with me the scan result. Yeah.
So we'll definitely do that. But would it be all right if we discuss a few things just to put them in history into context? Yeah.
Oh, yeah, sure, doctor.
So, I mean, before calling you, I've gone through your records where you have presented a few times with tummy pain and water infections. And how are you feeling at the moment?
To be honest, not great, doctor. These pains are still there, and it's affecting me to continue my practice. So I'm a professional rugby player, and I can't keep taking these painkillers just to be able to continue my training. There must be something there. I'm not sure it's a stone or something. And also, the scan doctor told me I need to come urgently to my GP because there's something that needed to. I hope it's not something, but I think it's only stone. And this is what I'm guessing because it seems that the pain of a stones, as your colleague told me from before.
Yeah, so we'll definitely discuss that in a bit more detail. So, are you all right to talk at the moment, or are you still in pain?
Oh, no, no. I just took ibuprofen, so it killed the pains, thankfully.
So that's good. So, I mean, the pain can how much would you say it is on a scale of 0 to 10, 10 being the worst pain?
I think it's five, doctor.
And is it on both sides of on the left and the right side of your
Yeah,
lower back?
yeah, usually will come in both sides, doctor.
And does it go from the back down to your groin as it was in one of your a few months back when you presented to the surgery?
No, actually, now it's mostly on my back and coming to the front, not
Okay.
down, not going to my groin area.
And is it associated with the nausea or vomiting?
No,
Okay. And just to talk about your urine symptoms, any burning down there?
no. I mean, sometimes I will find some blood in the urine, but there is no burns. Since I took the antibiotic 1 month ago or 2 months ago, there is no
Okay.
waterwork infection symptoms.
And what about okay, no symptoms. That's nice to hear. And when was the last time you saw blood in the V?
It's not consistent. Sometimes after the training, I would some blood in the wee.
Yeah, I understand. Yeah, yeah. And to talk about headaches. Can
Mhm.
you tell me a bit about them? And when was
Yeah,
the
I
last time you
had, yeah,
experienced?
I think 2 months ago I had that severe headache, but thankfully now I think your colleague said it's stress because really we had an important match. and
Yeah, yeah,
and I was stressed, but then it's gone. It really
yeah.
coming, and also I'm taking, and the ibuprofen is doing all the tricks, to be honest.
Okay. And was it associated with any neck stiffness
No, no neck stiffness.
and any blurring of vision,
No,
any chest pain?
no, no, no chest pain.
Any shortness of breath?
No, no shortness of breath.
Okay, so Jack, I can hear these the frequent visits to the surgery, the headaches and the tummy pains are affecting your training, and you have to take time off training a number of times. So that's definitely you're going through a difficult time. I'm so sorry for that. So, any thoughts that go through your mind as to what the scan might show?
Oh yeah, doctor. Oh yeah, might be stones, isn't it?
Okay, yeah, we'll talk about that. And what concerns besides the training do you have about it?
Well, doctor, the pain is not normal to live with pain, isn't it, doctor?
Sure, of course, of course. So just quickly, Jack, is there any family history of kidney disease or sudden deaths?
No,
And do you smoke at all?
no, doctor. I'm a rugby player. I need to keep healthy, so I'm not smoking.
Any alcohol?
Well, no, even I don't like the taste of the alcohol.
Okay, that's good to hear. So, to talk about your ultrasound report, this basically shows that both your kidneys contain numerous fluid-filled cysts. Yeah, they are varying size in both kidneys.
Okay. Uh,
Yeah,
okay.
so yeah, and
What
as
does it mean, doctor? What does it mean?
so it means that
Fluid-filled
both,
cysts.
yeah.
Uh-huh.
So both your kidneys has quite a few cysts in each kidney, and each kidney is full of cysts, full of fluid. Yeah, and
Okay.
this condition, in medical terms, we know as polycystic kidney disease. Have you heard about this before?
No.
Okay. I mean, now I'll definitely explain that to you in a bit more detail. And now that you know about, should I first explain you? Then I'll ask you your concerns once again. Yeah.
Sure, doctor. Yeah.
So this is a condition whereby you know kidneys develop cysts, and as a result of which gradually over time lose their function. Yeah.
Oh,
And yeah, I know it must be I mean it must be hard to hear this that this result, and I'm so sorry for it. And as a
uh,
result of
uh,
this, yeah,
I
yeah,
was not expecting that, to be honest, doctor.
yeah,
So it's
yeah,
not a
I'm so
stone,
sorry.
doctor?
No,
It's
no,
not
it's
stone?
not a
Are
stone
you
at,
sure, doctor?
yeah, yeah, it's not a
So
stone at all.
from where I
It's
get it?
most, yeah, I will just explain this to you in a bit more detail. So um, uh, this condition gives rise to the blood in urine and the repeated pains, tummy pains that you're having, and the repeated water infections. So this condition um, can is I mean it's that has a number of causes. One of them includes genetic cause. That means it is genetically inherited from one generation to the other. Do you understand?
Yeah, doctor, but I don't have anyone in my family have something like that.
Okay. Uh, um, uh, um, that's the exact reason why I asked about kidney condition in the family and sudden deaths due to some bleed in the brain. So, and, to determine whether you have the genetic cause behind this polycystic kidneys, I would want to refer you to the genetic clinic. Is that all right with yourself?
Yeah, sure, doctor, but until you refer me, what should I do with myself? Because now I'm worried. So, what is the drawback of that disease?
I'll definitely talk about that. So, to come back to your concerns, what are you worried about, Jack?
I mean, because now you are saying a cyst, is that will affect my kidney function or something, or what will happen to my kidneys?
Yeah, so let's talk about that. So, on referring you to the genetic clinic, now we will determine whether you have the genetic reason for your polycystic kidneys, and if that's the case, then we call it autosomal dominant, meaning a person. I mean, the person um, I mean, if you have children, then every child has a 50% chance of getting the same condition like you do. So, having said that, does that make sense?
A little bit. So now I can't have children. You know, if I get a children, I will make them sick. Is this what trying to say, doctor?
What I'm trying to say is, if you have the adult dominant polycystic kidney disease, then 50% of each, and you have children, 50% of each child will have the same disease. Yeah, that goes genetically. As far as your kidney health is concerned, there's lots we can do to support. And since we are running out of time, should we book a follow-up call anytime this week and then discuss in detail how to support you as far as your kidneys are concerned?
Yes, doctor. I think I need to come and see you because over the phone I'm not getting it, to be honest. Would you mind
Okay,
make an
definitely.
appointment with me?
Definitely. So we'll definitely organize a face-to-face appointment this week, where I mean in clinic I'll be able to examine your tummy. I will examine any if I'll be able to feel for any masses in your tummy. I will also be able to take your blood pressure, pulse, and temperature just to see if you're doing well. And on your way in, will you be able to bring a urine sample so that we can test it in the clinic for blood infection and protein?
Okay. Why is that?
So, as I said, we'll be able to test for any presence of blood infection or sugar in it. Yeah.
Okay.
Yeah, and if you have high blood pressure like it you had once a couple of months before taken at the surgery, we will start you on medications we know as ACE inhibitors. Yeah, but that depends upon whether your blood pressure is on the higher side. And there's a tablet we know as tolvaptan, which is usually given by the specialist, the kidney doctors to whom I'll be referring you to. Yeah,
What
those
is that?
tablets.
Yeah. What is that?
Yeah, and I was just explaining it to you. It's a tablet that prevents further increase of size of the cysts. um, uh, uh, um, um, it'll just halt progression of the cysts growing bigger. Does that make sense?
Okay, doctor. So would I lose my kidneys? This is what I'm getting.
Come again.
Would I lose my kidneys?
So, Jack, only time will say how, I mean, how fast or at what rate your cysts enlarge. However, whilst you are in clinic, I can request my nurse to do blood tests so that we can look into your kidney functions, liver functions, your full blood count, and thyroid. How does that sound?
Yeah, sure.
We also promote a lot of healthy lifestyle choices. For example, regular monitoring and checking of maintaining your blood pressure within normal limits, low sodium, low salt, a lean protein and high fiber diet. Yeah, as far as your training is concerned, I think you will not be able to continue with the training, I'm afraid,
Why?
because that's contact sport, isn't it?
Mhm.
There's a risk that the cysts in the kidneys might rupture, leading to further damage. So I would highly recommend not to continue with this sport.
Oh my God, doctor. I'm getting a
I'm
lot of
so
bad
sorry.
news, doctor. I
I'm
cannot
so
stand that,
sorry.
doctor. I can't stand that, really. All this.
I'm so
So,
sorry.
what I will do now? Let's see.
Yeah.
Maybe the
So
insurance will cover me or not. This is a big story now. Okay, doctor. Okay, that's fine.
we will definitely talk a lot about this when we see you in a few days' time at the surgery.
Sure, sure, doctor.
Thank you.
Safety netting? No, no, thank you. Where is the safety netting?
No,
What one?
yeah,
Safety
yeah.
netting, yeah.
So safety netting, if you um if you have severe headaches with stiffness with stiffness of your neck or severe tummy pain, or blood in urine, immediately seek medical advice.
Okay, doctor. Thank you.
Take care.
Okay, well done. Sorry, I needed to be a little bit rude at the end, so you will never forget safety netting at all. Okay, safety
You were
netting
not,
is part,
yeah,
yeah, safety netting, never forget. Okay,
you were
good, well
not rude at
done.
all.
Yeah, okay,
Yeah.
good, well done, well done. So looking back, so what you will do, what's your reflection? What you will do different, and what you will do the same, or what you will do different?
So, Dr. Slim, I will um, um, uh, um, I would what will I do different? So I did manage to complete my data gathering by 7.5 minutes, and then I
Mhm.
rushed to management. But I mean, the management of this condition is so lengthy. So
Part of it, I put a lot of obstacles in it just to make it a little bit challenging. Okay. Patient have no family history. Patient have a contact sport occupation, which is something you need to challenge it. And then patient he came, I think 1 month or 2 months ago, his blood pressure was high and that was not addressed. Yes, so by having hematuria, that was not addressed. And then he have a lot of queries and questions. And usually a patient having such new diagnosis, yeah, you will give it to him over the phone, but you will not do the referral without examining the patient and making the follow-up, making the rest of the needed investigation. Yeah, you will do the referral, but then until he been by the specialists, you need to do your part of work. Okay, there is a lot needed to be done, and you
yeah,
can
but
just yeah.
Dr. Salim, he presented to the surgery 2 weeks ago, and he must have
Mhm.
been examined there. So that's why.
There is no must because there is no must because what is not written is not done. Okay, nothing was written, isn't it?
Yeah.
And even though this patient came with UTI, hematuria. You can see there is here a lot in this story. There is multiple things to learn from. So if we look here from the beginning, 2 months ago, he came, okay, he have stress and training and they dismissed the headache that is a tension headache with high blood pressure. And they told him take painkillers, isn't it? Naproxen, and his blood pressure is high. I won't do that, to be honest. I want to give non-steroidal for a patient who have high blood pressure uncontrolled and not in medication. That will increase his blood pressure. And then he came with a male patient having UTI is not something common. Okay, don't take UTIs in males very lightly. Don't take it lightly. If male coming with
Yeah.
UTI, you need to be cautious. Why this patient have UTI? So old age, yeah, prostate, but then 31 years old or 35 years old coming with UTI, is it STI perhaps? Is it if he deny any sexually encounter, then why he have UTI? Is it reflux? Okay, psychoreteric reflux is common, is not uncommon, and it will make the patient suffer in his 50s. So catching it now will save the kidney of the patient. So why? They just give him the antibiotic and they told him everything is fine. Okay, that's fine. I do appreciate what they did, but then after that, at least you say that there is a blood in the urine at least after clearing the infection. That's a learning point. After clearing the infection, if the patient have urine dip and there was a blood in the urine, you need to have a clear sample after treatment of infection. Don't dismiss that. If patient have microscopic hematuria or macroscopic hematuria and you think it's due to infection, you need to do a cure test to see if the blood test, if the blood cleared from the urine or not. If it didn't cure, then there is something else happening. You need to investigate either hidden hypertension, either polycystic kidney, either tumor in the ureter, either tumor in the bladder, either prostate issues, or he have, normal cause of microscopic hematuria. That's will be by exclusion, but don't dismiss it because you will find something. And don't accuse anticoagulation if patient old and he's taking warfarin or taking apixaban or doxaban that, oh, this is the cause of microscopic hematuria. No, you need to investigate it. You need to know why there is microscopic hematuria. Okay, and then thankfully one said, oh, he might have a renal colic. Let's do ultrasound, and then the ultrasound, you know was done, and there is a couple of hints saying that this is maybe autosomal dominant, not recessive. The age of the patient, this is one, and the other thing when they tell the liver and the pancreas is normal, this usually autosomal dominant. Autosomal recessive will affect the liver most probably. You will find some cyst in the liver, and hence the pancreas will be affected. So this is what you can, when in the 3 minutes reading you need, to scan it, and then get all this understanding from it. Okay, that patient been struggling 2 months. Now, what is the blood pressure look like? And you did ask about the side effects or the symptoms of uncontrolled hypertension, and I like that. You might not need to ask a lot about the symptoms of the cysts. Okay, with the polycystic kidneys, because you keep asking about what is the pain. Where is it? Is it radiating down? Do you have any infection now? You might not need to go all through all of that, and that will save you time because already you have the diagnosis. Yeah, you already have the diagnosis here. So asking the question will not make a big difference in your management unless if you are, if you are searching about complication, okay, like the infection, like the hypertension. So going to search about complication will be your goal in your data gathering. And then if you have time, then you might ask about, the other symptoms of the polycystic kidneys. But I would go for the complication, okay? Headache, blurred vision, yeah, chest pain, heart racing, shortness of breath. You have tummy pain. How about your bowel? Is you are opening your bowel fine? Do you have nausea or vomiting? No. Okay, you don't have any problem with your erection because that's also important with the hypertension. No. How do you have any problem with your legs, like intermittent claudication or pain? No. That's it. This is what you need in the data gathering. Uh, Asking about the complication, direct to the complication, that will save you a lot of time. rather than ask about how is the pain, how, because he already told you the pain is high and he's taking naproxen, and that needed to be addressed because this patient shouldn't be on naproxen. Okay,
Yeah.
he
Yeah.
will shatter his kidney. So what else you would think in changing?
So, I mean, he needs to be started right away on Remipril. He needs blood tests. He needs a referral to nephrology.
Oh,
He
yeah, yeah. I'm
then
listening to it.
he needs to stop playing rugby completely.
Yeah, that's the
And
most important thing, and I think that will be difficult to, to be done only over the phone. Okay, that's what. Yeah, we'll tell him we need to discuss your rugby playing, but you need to stop until like you come and see me, and we'll discuss that further. And because that is the most dangerous thing. One knee in his renal angle, he will have a valved kidney, and that's fatal. Okay. So that's important to be addressed, and you did address it. I like that. What else?
no nephrotoxic medications like naproxen or ibuprofen, only paracetamol
Yeah, yeah,
for pain, or we can give
yeah.
codeine if it's bad.
Which here also a little bit contradiction, isn't it? So is ACE inhibitor not nephrotoxic drug?
So, it is not nephrotoxic. It is nephrobeneficial. And
Well, no, that's with limits. Yes, it's nephrotoxic and also renoprotective. Sometimes it's nephrotoxic in such situation, and sometimes because when the patient have high potassium level, you will stop it, isn't it? So yeah, it's not always, but in that situation, it's beneficial, and we will know why. Okay, why? Because the hypertension and polycystic kidney disease depend on the renin-angiotensin system, and we will have the why the physiology behind it. So they will have high renin activity because of the compression of the cysts. The cyst will compress on the blood vessels of the kidney, and that will make will make the renin-angiotensin system activated and the RAS system will be very high active, and that's why the ACE inhibitor is the optimum in treatment in this situation. Okay, and usually we are aiming for lower blood pressure. So if the target 135 over 85, we are aiming to 110 over 75. That's important as well. Okay, what else, Satwat?
so then referral to a nephrologist who will start tolvaptan. There's lots of research
Yeah,
around it.
yeah, this we'll discuss in the management. It's just I want to add some couple of things. You did a good thing there because I think you learned that last time we said if the patient is bleeding, we need to make sure that he's not actively bleeding. So even and the patient, if you are suspecting that he is in pain, you need to make sure that he's not actively in pain. And you did that very good. So you ask him, "Are you in pain now? Are you fine to talk?" That was good. And then you did ask about the symptoms of the polycystic kidney and then the complication, and that was good. You maybe you didn't ask about a little bit about who's supporting it at home, because who's living with who's support, because when you want the patient to come in the clinic, you need to bring someone with him, okay? Because that's considered as breaking bad news. Yeah, you break some of it over the phone, but then you need to tell him that you most probably you need in the future, maybe you will need renal replacement therapy or even kidney transplant. So you will need him to be with you, someone to, with him, his partner, his father, his mother, whatever. He need to bring someone. And just saying that, would you like to come tomorrow, bringing someone with you? That's a big hint of that there is a massive bad news you will break. Okay, this according to the British culture. When you say something like that, they will know. The doctor need to tell me bad news, so I need to prepare. Okay. It's just when you ask about the ice, so idea, yeah, it's just please try to acknowledge what the patient told you. Okay, he said, I know that there is a stone. Okay, and also I'm worried about the pain. So you tell, okay, other than the stone, did you think that might be there's something else other than the stone? or and you are worried about the pain with that, there's anything else other than the pain you are worried about, okay? Otherwise, you will be downgraded in the active listening, okay? So be aware about that.
Yeah,
And
yeah.
then patient playing sports, you need, yeah, you did ask about smoking, alcohol, you did recreation drug, maybe there you can ask, but don't forget energy boosting drugs, okay? Because most of them containing ephedrine, or even hormones like cystone or testosterone. That's important to ask. And patient, highly active, okay, or he's taking energy drink. So energy drink contain a lot of caffeine, and that will increase his blood pressure and will put a burden on the kidneys. Okay, just add it in your question. Okay. And then in the management, you did start with, you have, something called, the ultrasound scan didn't show. Always start with the positive things. Okay, the ultrasound scan didn't show that you have a stone, but actually we can see that you have what is called polycystic kidney disease. Are you aware about that? Did you hear about that from before or not? For sure, after asking family history, because usually in such instance, so any genetic disease, I'm using the family history to go through the breaking news. Okay, so I will ask him first. Do you have anyone in your family have kidney issue, kidney problem, renal failure or kidney failure or what's called polycystic kidneys? Have you heard about that? No, doctor. No one has in my family that. Okay, and then I would break the bad news from it because he might know. Okay, if he say, yeah, well, I know the polycystic kidney, my father had it, or my grandfather had it, and so what he had it, how bad it was. Then you need to know the experience of the patient regarding such genetic disease because you need, to see the background of his experience and compare the background of the experience with now. Okay, so for example, if his father, oh, they discovered it very late and he was breathing was bad. We went to the hospital. They said he have kidney failure and then he need to put him in dialysis. And then his situation is different because most probably he's still not in failure. He's active, he's healthy, he's young. So then we discover it now. Don't worry, there is a lot we can do. Yeah, it's not completely treatable disease, but it's controllable. And there is a very good medication that we can offer to you that can buy you some years of good living, okay, which is toluvaptam. So, okay, so you can break the bad news by giving him some hope. What this is what usually I would do, okay? And
Yeah.
then an explanation, what is polycystic? Yeah, it's fluid-filled cyst. To be honest, a little bit vague, isn't it? So what? Because I'm not sure if every patient know what is cysts. Okay. Well, usually I'm saying it's a fluid-filled sacs. They know what is sac. Okay, multiple sacs around the kidneys, fluid full of fluid, and these sacs will grow by time, compressing in your kidney, making your kidney function, to deteriorate. However, there is a lot of support. One of them is that tablet. Also, there is lifestyle modification we need to do and control your blood pressure, and make it an optimum number. The stopping. So you might just, if you find that the time is running, just enumerate your management plan and hints, and and bullet points. So and then you can expand on it after you finish your bullet point. So lifestyle, drugs that you need to avoid, the drugs that we will give to you. At the same time, we need to do some blood test and control your blood pressure. And that, so like that, you summarize your management plan. It's 5 points, 6 points. Summarize them and then expand on them as much as the time allows, and tell him, okay, the rest we will discuss when you come tomorrow or today in the afternoon. Does anyone want to say something, or Dr. Gigi? Can you mute? Okay. Okay. Is that clear, Satwat, or clear to the other doctors? Or if someone
Thank you
want to
very much.
say something. Yeah, so if you enumerate them, that will help in you to to control the time. Okay, and then you expand according what the time allows. Okay, And then, yeah, just he throw you with multiple, multiple obstacles that need to be addressed, okay? Because that will have a mark. So if he said, okay, doctor, but I don't have any family history. So can anyone answer that, including Satwat? So how you will explain that to him? Well, doctor, I don't have any family history. No one in my family have this disease. How you are telling me is this disease that is running in the family?
So, Dr. Salim, it's not always
Hmm.
that a person who has polycystic kidneys has renal damage as well. The cysts don't grow at times; they are static. And the patient does not have a renal failure till
No,
and
no. This is not the question. The question is, you said that this disease is running in the family, isn't it? And it's running in the families, yeah. But then if he told you, yeah, please answer, Dr. Mona.
Yes,
Dr.
because sometimes what happened, sorry, yeah, Assalamu alaikum, I'm Dr. Mona.
Walaikum salam. Hi, Dr. Mona. How are you?
Yeah, so I think sometime what happened, it's there is this gene, sometime by chance in the womb, it become like altered. So the infant is born with the polycystic kidney despite having the two healthy parents. So can sometime happen
Yeah,
like this.
exactly. So they find that around 5% to 25% of the cases can have pure new genetic mutation. Okay, new genetic mutation. So yeah, so it's running in the family in most of the cases, but then there is some cases that you will find a new genetic mutation. Okay, which around from 5 to 10%, from 10 to 25%. Yeah.
yeah.
Is that clear how you will answer this? Yeah. This is one. Also, the rugby, you did address it. Um, what also he would say, okay, so would my kidney be damaged, doctor? Then will I would have damage to my kidney. Then they will say about the tolivaptam, and then that can buy you a good new years and okay. The other thing, okay, then if I had a kidney failure, so no, don't worry, it's not the end of the world. We have advanced technology now. We can give you either renal replacement therapy, which can be either peritoneal, either hemodialysis. The peritoneal dialysis, they are doing it at home. He doesn't need to go anywhere. He can, 1 or 2 hours at home. So it's more convenient. So that's an option. Or renal transplant. So that there is a lot of options, isn't it? And then when he throw you with Satwa, did you leave? Yours there, yes or no?
Yeah.
Okay, yeah.
Yeah.
So if yeah, I know, because I know you like to cook at that time. Soon I will go through the PowerPoint. Don't worry. Yeah. So the other thing is about what if he told you, what about my children? Kid, is I'm allowed to have a children or not? And you said you will give him to the genetic. That's true, genetic, and then you will send him to nephrology because the anti-vasopressin tablet, it should be prescribed by the nephrology. So how you will address the children?
So, like I said, Dr. Salim, um, once the genetic clinic presents your report as autosomal dominant polycystic kidney disease, at that time, you need to discuss the report with your siblings as well as your kids, because as far as the children are concerned, I mean, it is thought that I mean, some say that until they are mature enough, or age above 16, there's no point of telling them, because it's associated with unnecessary stress. However,
Yeah.
there are new medications available like tolvaptan, which, when introduced at the right time, prevents further progression of these cysts. So better safe than sorry. Yeah.
Yeah, exactly. So you will tell him, well, you have multiple options. So that if he have a children, okay, it's you might put them in unnecessary stress now because most probably the cyst will not appear before the age of 40. Okay, and usually will not do ultrasound. They need an MRI. We can consider, put them in the surveillance after, after that when we go and see what also the nephrology team would say and the genetic team what would they will say. For having future children, you can use, either, surrogate sperms, or you can, or sperm donation, or he can use the pre-implantation or pre-implantation testing. Okay, that's also an available services. But if you have a children, they will not offer him that. Okay, these people that they don't have children, so they can offer him that. But if he have children, either his partner have a children, he will not be offered that. Okay. And yeah, these are the obstacles that I want to address. And then don't forget the blood pressure. You need to do blood pressure readings. He come and he need to do all the cardiovascular screening. So lipids, kidney function, liver function, that need to be done. And as you said, the ACR and the urine dip, that also need to be done. Okay. Coming back to the PowerPoint, okay, we might see then the example consultation, and this is the new thing in this teaching week, okay, that we have an example consultation, okay. So these are the consultation that we have example of it. Okay, the patient name is Mrs. Smith, and she is 34 years old. Okay, and she came with the provisional renal stones, um, and now the doctors are explaining to her in simple terms what is kidney, what is polycystic kidney. So I will open the consultation, we'll listen to it, and then we will go through the PowerPoint. Okay. I hope that will not be boring, but I think you will learn a lot from listening to this consultation. If you are not hearing, just let me know, okay? Because when I try it, I guess it's working properly.
Hello there, is it Miss Smith?
It is.
Hello there, my name's Geordie Morell. I'm one of the doctors in clinic today.
You are hearing, doctors, yes?
Yeah.
Yeah, okay, so I will open it, yeah.
Yes, yes.
Yeah, that's good.
How are you doing?
Well, not very well, really.
Oh dear, why is that?
Well, I've been having these pains, and
Right,
it was in my stomach really to start with, and side now they've moved
Okay.
into my back more,
right, okay,
which is why I went to the doctors.
I see. And did your doctor give you any indication what he thought was going on?
No, I mean, I thought at first that it might be, an ulcer or something.
Okay,
He sent me here and I had some tests.
Okay.
And I must admit I did ask what the tests were for and
right,
was absolutely horrified. It was my kidneys.
yes. And have you had any experience of kidney problems before?
Yes, my
Right,
father's got
right,
kidney problems.
okay. What type of kidney problems does he have?
Oh, it's this cystic something,
Okay,
polycystic fibrosis.
right,
He's on hemodialysis.
I see.
And that has frightened me between the test and
Right,
I'm terrified today.
okay. What is it that makes you so
Well, in
worried?
case I'm the same. It's just never occurred to me that it might be that. I don't live with my parents now,
Yes.
I've got my own flat,
Mhm.
but I've not talked about my symptoms because they've both got quite enough to think about with my dad, Possibly if I had, he might have given a warning shot.
Right, and from what you're telling me, it sounds like he suffers quite badly with this. Is that?
Yeah, he's been on two sorts of dialysis and he's now on hemodialysis. That's worse, isn't it?
Well, there are different types of dialysis. I wouldn't say
He's
one is worse.
peritoneal.
Peritoneal dialysis.
He was on first.
Okay. Fine. And how long has he been on treatment for?
Oh, years.
Okay,
20 years.
Right,
And
okay.
probably more than that.
fine. And you're worried that you might have this?
Well, I am now, yeah.
Right, okay. Well, today is this ultrasound scan that you did of the kidneys, and it does show features of this adult polycystic kidney disease, I'm afraid.
I never knew it was hereditary. It's not chance, is it?
No,
It must be hereditary.
it does tend to run in families. It doesn't happen. It's not something that's automatically passed on from like in this case, father to daughter. I wouldn't have automatically assumed that you'd get it, but it does increase your chances of getting it.
This really, couldn't have come at a worse time.
I'm sorry. Why's that?
Well, I'm due to get married in the spring, and
right.
because I'm 30, we were going to start a family immediately, and they're going to be in line, aren't they?
Well, as I said, it's not necessarily. The genes that people pass on to their children are very much dependent on the genes of the other partner as well. And I say that there is a risk, but it's not a definite.
Is there anything I can do to protect them?
Well, what we can do is there's a lot of research being done into why people inherit this condition, and we can do the genetic testing on yourself and on your partner. Obviously, we'll want to we'll need to talk to him first about what he wants, but I can't go.
He might even run a mile.
I don't think that's gonna.
I mean, sort of getting back to me, how bad am I? Am I going to need dialysis?
Not at the moment, no. Your kidney tests,
So
other than
I might
the
have
scan,
a few years.
you may have. Many people have this condition all their lives and never need to go on dialysis. So it's not a definite.
Right. Am I going to have any treatment now?
Well,
Is there anything that delays it getting to that stage?
In terms of what's happening with the kidneys, it's about, I'd be looking for all of the other reasons why people's kidneys might become impaired. So this condition is, relatively speaking, rare in terms of the people who end up on haemodialysis, like your father, or even peritoneal dialysis, as he was on before. The most likely problems are things like diabetes and high blood pressure. So I would be probably looking more at those things. Your kidneys are not normal in their structure because they've got these cysts, and that's where you're getting the pain from.
Right.
Because the cysts will either stretch and cause the kidney to become tender, or sometimes they can actually pop, and that causes some discomfort as well.
Right.
Now, in that respect, the treatment's going to be about pain relief and making sure that we are controlling the pain.
Yeah, I guess that was going to be my next question. I mean, what will you give me for pain relief? Am I all right taking medicines?
There are certain
or diet. Do these help or
there are
make
certain
things worse?
There are certain medicines that are certain painkillers which aren't so good for the kidney, and so I'd probably steer clear of those where possible. And those are the anti-inflammatory drugs like ibuprofen or diclofenac.
I've been taking ibuprofen for this back pain.
Right. And does it help?
This is only recent.
Right.
It does, yes. Well, at least it takes the edge off, makes it bearable.
Well, the class of drug that the ibuprofen are we refer them to as a sort of an acronym of NSAID, which means non-steroidal anti-inflammatory drug. So what would actually be a better tablet for the kidney is is the S, the steroid. So that would actually perhaps help with the pain, but not have the effect on the kidney. Don't worry about the tablets you've taken already.
Well, I've not been taking
No.
them for very long because
No.
I haven't had the back pain.
It takes a
Too
long
It was
time.
more stomach pain before that.
It takes a long time for them to cause damage to the
Yeah.
kidney. So I wouldn't worry about those, but I would use those at most very sparingly. And we'd be much better with other painkillers. Like paracetamol is a very underused tablet, and it's very safe and
Doesn't do very much though, does it? I mean, it's all right for headaches,
But what it does do is it gives us a good baseline to work from, and then I find that it helps the other medications actually be a bit more effective.
yeah.
So if you took paracetamol regularly, and then an occasional tablet like codeine, it tends to be a bit stronger than the codeine would be on its own.
You mentioned steroids. I guess I'm going to be on tablets sort of for a long, long time. Is that not dangerous in itself?
I wouldn't want you to be on the steroids for a long, long time, because as you've said, there are problems with people taking steroids for a long time, and it can cause weight gain and thinning of the bones and thinning of the skin, and these are things that it takes a while to cause a problem with, but they're potential problems if people are on the steroids for a long time. What we tend to find with conditions like this adult polycystic kidney disease, it's been there for a long time. It's probably been there to some extent since you were born.
Yeah.
And it's just that we've come to problems. So we've managed, how old are you now? 20?
30.
So we've managed 30 years without a problem, and what we're probably experiencing now is a bit of a flare of the condition. So it might be that some steroids for a short course, by which I might mean a week or maybe two, or maybe shorter, and we might get the symptoms settle down. But we'll have to see.
Yeah.
We're going to be, you're now on our books, okay? Don't find that threatening, but that means we're going to be looking after you at regular intervals and checking in with you.
Day trips here.
Yes, not every day.
No.
We'll keep them down to as much, but it means that we're there for you. So when you leave here today and you think, oh, I meant to ask this, we're on the end of the phone. So you can go.
Right, thank you very much.
But in terms of how things are going to pan out in the future, you may never need to go on dialysis or anything like that. And I think when you've had the chat with your partner, and we can help with that in any way. And
what about the question of transplant?
That's certainly there's we mentioned briefly two treatments for kidney failure. And as I say, at the moment your kidneys are working perfectly.
Right.
When we get to that point of looking at kidneys failing, which I stress we might not do, there's broadly speaking 4 options. Number 1 is we do nothing, and we treat with medicines and manage the kidney failure as best we can.
Die.
Some people live for quite a long time without any treatment, but it's a choice, and it's something we work out together, and it's something that suits you in the end of the day. We mentioned hemodialysis, which is you know from looking after your father, he goes in regularly to the hospital and will have essentially his blood cleaned. So the blood is drawn through a machine, does the job of the kidney, and then gets the clean blood, in inverted commas, gets put back into him.
2 minutes.
Thank you. The peritoneal dialysis is does the job of the kidney, but in the stomach cavity. So we pour in a specially composed fluid, and that will allow the exchange. Basically, allows the blood to be cleaned through the lining of the gut.
Ooh,
I know that's but I say we're not necessarily looking at any of them, and it is a choice for you. And then you mentioned transplant, and that's option number 4. Many people, we keep a monitor of their kidney function, and when it gets to a point where we're worried that the kidneys aren't working properly, then we start looking at the possibility of a transplant. And that's ideally comes from a living person. So what people often do at the early stages of when their kidneys are beginning to fail is talk to family members about the possibility of transplant, and we do tests, because in the same way that your genetics have passed from your father and you develop this illness, we want to check and see the genetics of the person who's giving you the kidney. Are they right for you? Will the kidney work properly? In rare cases, well, more commonly, but not as more commonly than we'd like, the kidney comes from someone who's died. So carrying that all-important donor card can, in some cases, mean that they donate a kidney.
And I suppose the flip side of this is it's better a bit earlier than later, because they won't put you on the list if you're too old, I think.
There's people. I'm not sure. I can't say for sure what the cut-off age is, but they certainly look at all the options till quite late on in life, because people are living longer and longer and are, maintaining a sort of relatively active lifestyle till late on. So we don't want anyone to miss out simply because they're a little bit old. And I think you're as old as you feel in some respects. But again, we're probably a good 30-40 years away from narrowing your options down. So there's all of those options, but we're well in the future there. And I think we're just at the beginning. And yes, you're going to be
I think the thing that worries me most is the children. Have children. I think it's a big risk.
Well, I believe that adult polycystic kidney disease is an autosomal recessive inheritance. So this would mean, in practical terms, if unless her partner was a
I hope that was helpful. Yeah, doctor, do you hear me? Just someone can confirm. Yeah,
Yeah.
you are hearing me. Yeah, I hope that was helpful. I think it's good to listen to original consultation like that. That will help you, to improve your way of consultation. Just pathophysiology-wise, it's important just to understand. We know that the nephron is composed of Bowman capsules and then convoluted tubule
Yes, sorry,
proximal.
Dr.
Yeah, sure.
Sorry, Dr. Salim, may I ask a question? Why
Yeah, sure.
is the genetic testing of the partner important?
Oh, in that instance, just because you want to know because if the partner is autosomal, have the genes and she have the genes, then means that 100% of the children will come having the disease, isn't it? Yes. So that's why they are worried about that. Or if the partner have autosomal recessive gene and then she have autosomal dominant, then the children will come how the child more than 75% will have the disease. That's only. But you will not mention that in detail. So what you will say will refer to the genetic testing, and they will take the things further on. And they are not taking these things lightly, by the way, okay? Because that's considered a good resource of, researches. So they are doing the genetic testing for most of the cases. Yeah.
Thank you.
Yeah, no problem. Okay, so and then that's the normal shape of the nephron, and then the lining. The problem is when there is a gene modification, then the lining of the nephron have the problem. Okay, because the cilia of the nephron will not be working properly, and then that will make the proliferation of the cell happen, and that will make the cysts. And as the proliferation happen and the cyst formed, it will start to compress over the surrounding structures. Okay, so this is another way to show it. So you can see here, this is the proximal convoluted tubule. cyst formed, and the cyst will start to compress in the surrounding structure, including the blood supply here. And once the blood supply is, compressed to the nephron, that will activate the renin-angiotensin system. And once the renin-angiotensin system activated, the blood pressure will go high. And that's why the ACE or ARBs are beneficial. Some nephrology doctor are combining both ACE and ARBs, but that depend on, on their experience. There is no specific study regarding that. Okay, combination of both these drugs, because both of them are working more or less the same, and maybe combination of these two drugs may hurt the kidney, but they are the specialists. They can do that, not us as a GP. We can't do that. Either ACE, either ARPs. Okay, and then the cyst itself can rupture, make hematuria, or even compress on the calcial system, okay, and cause, compressions, renal stasis, infection, or stones, and hence the symptoms. Okay, so what about extra kidney? Why extra kidney? The things are affected. So the primary cilium is present on most of the tubular structure, okay, on most of the vessels, and actually when the genetics is there, so that will make the polycystin 1 and 2 is not there. So the polycystin protein responsible on absorbing calcium in this serum, okay, and then when the calcium coming inside, that will prevent the uncontrolled multiplication of the cells, and hence will prevent cyst formation. When these are absent, okay, calcium will not enter, the cell proliferation will be uncontrolled, and then the lining will start to form the cyst, either the cyst in the vessels, either cyst in the liver, either cyst in the pancreas, either cyst in the seminal vesicles of a male, and then that will give the symptoms of the extra kidney manifestation, okay, of the disease. And one of them, the liver failure, liver cirrhosis, seminal vesicle pancreatitis, aortic aneurysm, or perianeurysm in the brain, and then intracranial hemorrhage. I would like to share another animation. Sorry, I know that it might be a bit long, okay, but it's good to understand the disease, so you will be able to be more fluent if something appear in real life or in the exam. Okay, just knowing that, one or two points in how to manage the disease will make you forget with the stress of the exam. This animation that we will share is very good, very comprehensive, and will make you have a better understanding of the disease. I hope it will work.
Autosomal dominant polycystic kidney disease, ADPKD, is a rare genetic disease characterized primarily by the development and progressive enlargement of fluid-filled cysts within the kidneys. ADPKD is a systemic disease characterized by both renal and extrarenal manifestations. Over the course of disease progression, common sequelae include cyst infections, cyst hemorrhage and hematuria, intracranial aneurysms, hepatic cysts, hypertension, back pain, side pain, and urinary tract infections. ADPKD is an inherited condition. When one parent has ADPKD, their children have a 50-50 chance of inheriting it. However, even patients within the same family can present with variations in disease characteristics, such as age of onset and rate of progression. ADPKD can initially be difficult to detect because symptoms may be scarce in early-stage disease. Over time, the enlarging cysts can cause an increase in total kidney volume up to 4 times its normal size. The development and progression of these fluid-filled cysts can contribute to compression and loss of the surrounding functional renal tissue over many decades. However, in early-stage disease, healthy nephrons compensate for damaged nephrons, causing estimated glomerular filtration rate, EGFR, to be normal or slightly reduced despite the fact that damage is occurring. EGFR can remain intact through prolonged periods of time due to compensatory hyperfiltration, but will ultimately decline steadily thereafter. So while the enlarged cysts can ultimately contribute to irreversible loss of kidney function, the progression of ADPKD can be difficult to track because kidney function alone is not an effective indicator of disease advancement. ADPKD can progress significantly while EGFR presents as normal. In these cases, a normal EGFR may be masking irreversible kidney damage. In most patients with ADPKD, serum creatinine levels do not rise until a patient is in his or her 40s or 50s, when the kidneys are grossly enlarged and previously healthy parenchyma has incurred serious, irreversible damage. Therefore, it may be better to measure both EGFR and total kidney volume, TKV, when assessing disease progression. The two main mechanisms leading to cyst formation and expansion in ADPKD are fluid secretion and cell proliferation. A key driver of these mechanisms is an increase in intracellular levels of cyclic AMP. Cyclic AMP is a secondary messenger molecule that controls various cell signaling pathways. Cyclic AMP leads to the activation of CFTR chloride channels, resulting in fluid secretion. Cyclic AMP-mediated activation of cell proliferation has been shown to occur via activation of pro-proliferative pathways, such as MAP kinase. Elevated cyclic AMP levels in ADPKD are believed to be driven by two main mechanisms: impaired calcium regulation of renal tubular epithelial cells driven by genetic mutations of PKD1 and PKD2 genes, and elevated serum levels of vasopressin, an antidiuretic hormone, also known as AVP or ADH, and upregulation of the V2 receptor. The genes PKD1 and PKD2 encode proteins present in renal tubular epithelial cells. A mutation in PKD1 is responsible for a defect in polycystin 1, PC1, a transmembrane protein located on the primary cilia and cell membranes of renal tubular epithelial cells. Patients with a PKD1 mutation account for approximately 85% of all ADPKD cases and are characterized by rapid disease progression. A mutation in PKD2 is responsible for a defect in polycystin 2, PC2, a non-selective cation channel located on the primary cilia, cell membranes, and endoplasmic reticula of the renal tubular epithelial cells. Patients with a PKD2 mutation account for approximately 15% of all ADPKD cases, in which the disease progresses more slowly. These defects in either PC1 or PC2 can disrupt calcium homeostasis in the renal tubular epithelial cells, resulting in decreased intracellular calcium and a subsequent increase of cyclic AMP. This can lead to impaired regulation of the proliferative and secretory pathways. Vasopressin is a powerful modulator of cystogenesis via binding on vasopressin V2 receptors and stimulation of cyclic AMP production. Vasopressin levels have been shown to be elevated in ADPKD. Studies have shown that vasopressin is actually the main driver of elevated cyclic AMP levels in renal tubular epithelial cells. Studies have also shown that both vasopressin and mutations in the PKD1 or PKD2 genes are required to lead to the development of cysts in ADPKD. Therefore, impaired calcium regulation and elevated levels of vasopressin contribute to an increase in the production of cyclic AMP. In summary, increased cyclic AMP levels resulting from low intracellular calcium and elevated vasopressin lead to an increase in cell proliferation and fluid secretion, the main mechanisms of cyst formation and growth in ADPKD. Over time, these cysts contribute to an increase in total kidney volume, destruction of kidney tissue, and diminishing kidney function. And while much is known about the etiology and pathophysiology of ADPKD, advancement of the disease can often go unnoticed, as normal kidney function can mask the severity of disease progression until irreversible damage has already occurred.
Yeah, I hope that was clear. Okay, so the rest will be just a repetition of all the what we said. So this is the
At Monica
symptoms.
Vinader, we
Sorry.
craft luxury jewelry with artistry,
Okay.
expertise, and quality in every detail. We're inspired by you.
So the symptoms, we said the symptoms are the hypertension, hematuria, pain, and polyuria recurrent UTI, aneurysm, and this is the complication. Don't forget mitral valve prolapse as well. And then, all of that are just repetition, the vertical disease, aortic dissection. Okay, so that's summary of the treatment, which you can just enumerate it in the management plan, and then if you have time, just build up on it. Okay, and I think the videos was did go through the details of it, and this again, that's the type of the genetic autosomal recessive one. So 30% of the patient with autosomal recessive one, which will appear even intrauterine, the 30% will die very early when they are babies, okay, and the rest will present with liver impairment rather than, and pancreatic impairment rather than cardiovascular problems, okay? And here the two genes that is affecting the patient on autosomal recessive polycystic kidneys or PK1 and PK2, and we see just BKD1 is more common, okay, and more severe, and BKD2 is less common and less severe. It's not something that you might need to know about it, because that will be discussed with the patient with the genetic counseling. What you need to know is autosomal recessive. What does it mean? I mean ones and two, or 50% of the children have chances of having the disease, and then genetic referral is indicated. Okay. Um, the clinical feature, we already talk about it, and then disease management, as Satwat said, healthy lifestyle, treatment of hypertension and other cardiovascular disease, a statin of if the eGFR less than 60, that's important. This is the treatment even of the CKD, which we will have soon a case about CKD, and then the vasopressin V2 antagonist is tolvavastan, and then we saw the mechanism of it. Okay, and then the dialysis and the transplant. Well, one of the things of the lifestyle, you need to address the salt intake, okay, and also the rehydration and drinking of water, weight management, and then avoid smoking and non-steroidal. Okay, that's important. Blood pressure control should be 110 over 75. It's tighter goal control, and the best is ACE or ARBs. And then this is the statin if the EGFR less than 60. And then again, this is the mechanism of how the tolvaptan is working. And then you need just to inform the patient on these tablets, because you will follow them up, okay? They are coming to your clinic for that. Yes, there is annual review by the nephrologist, but you are the one who's following them up. So urea and creatinine should be done, and more frequent than the other patient, as well as encourage them to drink a lot of water, because that will make them pee a lot and will make them easily dehydrated. And then the dialysis, okay, and the kidney transplant. Keep in mind that usually they are leaving the old kidney, okay, to prevent cross autoimmune reactions. They give the old kidney and they will put the new kidney beside the old kidney. I finished now my lecture. There is a good source for the bkdcharity.org.uk. They are very good website. Will have a lot of information and a lot of example, and then patient stories. Um, the recording of this lecture will be in the YouTube channel. Please subscribe and share with your colleague. Let the people, and let the people know the channel. And please, we have a WhatsApp channel also. You might consider be part of it, and the Facebook, and for sure Be aware that I'm doing mini mocks and face-to-face and one-to-one teaching. Uh, Feel free if you want any help, to contact me. Any question, doctor, before we conclude? I know that it was a bit long lecture, but I needed to make it like that to make sure that all of you understand the polycystic kidneys. Otherwise, we are just, knowing the information without understanding it, and that's something will make you forgot. So like now, if you listen to this once, I don't think you will forget until, until long time, okay? Even after the exam. I think that it will be in your brain until even you become a well-qualified GP in the future. Yep. Any question, doctors? Anyone? Dr. CJ, because I feel I are there. Dr. CJ, do you want to have any question? Because you are unmuted yourself, I think. No? Or Gigi, Dr. Gigi, do you have any question? No? Okay, doctors. I will. You feel free to leave. Unless if you have any question, I'm more than happy, to answer it. Any question, doctors? No? Okay, so if you don't have any question, you might leave the call. I will just stop the recording, and also I will wait a little. If anyone needs any question, I'm more than happy to answer. Okay, the recording will be on the YouTube channel as